So there were key characteristics that are identified in a study that looking at different nursing care models. And when the nurse serves as a primary care manager, when the RN is the primary care manager, that is going to result in an effective model of care. It is generally more focused on the patient. And it results in greater patient and family involvement, faster recovery and compliance. And one thing that is used for that now is bedside reports. When you give report to the oncoming shift with the patient knows what's going on. The patient can participate. The patient can add their thoughts and their perceptions to the report. It provides better continuity, fewer lapses in care because everybody knows what's going on. There are indicators to measure satisfaction. The surveys are also used best with, when surveys are used, you end up with the most effective models of nursing. But staffing, let's talk about staffing briefly. Staffing is an issue because you never really seem to have enough nurses, right? How often do you have too many people working? Well, what happens? Somebody gets sent home or floated to another unit. Lower levels of hospital staffing is directly associated, has a direct relationship with more adverse outcomes. Fewer nurses, it's an indirect. Fewer nurses, more bad outcomes. Patients in the hospital are more acutely ill than in the past. Look at, when you go to clinical, how sick are those people? They're older and they're sicker. It actually takes a lot to become hospitalized now. When I was a new nurse working in cardiac step down, people that were going to have open heart surgery would be admitted the night before. The night before they would get teaching, they would go through cardiac rehab teaching, they would get all their tests done, they'd have their pre-op showers, all while being inpatient the night before. That doesn't happen anymore. If you're having surgery in the morning, you're going to arrive earlier in the morning. That's what happened to me. I had my knee let me try that sentence again. My knee surgery was scheduled for 7:15. I had arrived at the hospital at 5:15 for all my pre-op stuff. 20 years ago, I would have arrived the night before. Because the patients are sicker, they're higher acuity, which means nurses have more responsibilities for these sicker people. That's stressful. So avoiding adverse outcomes such as pneumonia can raise, adverse outcomes, when they happen, result in higher treatment costs. Pneumonia generally costs $28,000 to cure when somebody develops pneumonia in the hospital. Hiring more nurses, there have been studies that show more nurses do not decrease profits because more nurses results in fewer pneumonias. More nurses results in better quality of care for the patient and better nurse satisfaction for the nurses. We talked about how to keep nurses in the field. Hire more. More nurses working, more happier nurses. How are nurse assignments decided? It's going to vary across the institutions. Some places have mandated ratios. California has nursing ratios. I believe on a med-surg unit, a nurse can have no more than 6 patients. In women's health, they can have no more than 2. Critical care, no more than 2. The downside of that is when there's a law that says on a med-surg unit, one nurse can have no more than 6 patients, it doesn't say that the nurses can't have up to 6 patients. It says no more than 6. So hospitals say, okay, all med-surg nurses get 6 patients because we're following the law. 6. Doesn't matter how sick they are. 6. Now some facilities do look at acuity. So they might only get 3 patients, but these 3 patients are sick versus 6 light patients. But California doesn't take acuity into account. It's strictly numbers, which is why a lot of nurses hate that law because hospitals read it to say in a women's health, they can have no more than 2. We're going to give 2 patients to every nurse, regardless. And when I was doing supervision at Aurora, we had to count the number of people in the hospital at midnight. And based on that number, that's how we would set our staffing for the next 24 hours. Didn't matter how many people were going to discharge or be admitted, whatever's in the hospital at midnight is what determines staffing patterns for the rest of the day. Kind of messed up, but that's the way they did it. And based on how many patients, I had a chart that said I could have so many bodies, FTEs. I could, as a supervisor, I could divide them up however I wanted. If I was allowed, let's say, 10 FTEs, I could have 8 nurses and 2 CNAs, or 5 nurses and 5 CNAs, whatever I wanted. And obviously, I was encouraged to use more CNAs. Why? They don't get paid as much as an RN. But that's what was happening in Aurora back in the early 2000s. I'm not sure what's happening now. But every facility, every state will have its own rules and regulations on staffing. Personally, my opinion only, there will be no test question on my opinions. I think the state should keep their hands off of decisions like this. I think the person who's working, the managers who are working with their staff, with their patients, with their doctors, know best on how many people should be working at any given time to provide the best patient care and the best possible outcomes. My opinion. Other scheduling patterns that are used, some places use 10-hour days and work 4 days a week. Some work, it's called a Baylor plan. You work 2 12-hour weekend shifts, but you get paid for 36 hours. But you work every weekend. If you have no family, that's awesome. You work 24 hours, you get paid 36. You just work the weekends, you have 5 days off a week. You have a lot of fun having 5 days off, but on the other hand, you give up every weekend. When I was at Aurora, I did 3/12s, generally 3/12s a week. So I had 4 days off every week. That's not bad. I can work with that. Mandatory overtime, sometimes it's used. Some places use mandatory overtime a lot. It really should only be used for emergencies. We talked earlier that when you start working more than 12 hours, your risk of mistakes drastically climb. So mandated overtime should be used as last resort. Come back for the next section. We're going to start talking about more economics and more pure economics. It's going to get exciting.